Hello everyone. I, Dr. Seema Tandon, on behalf of RRTC team, welcome all the participants and especially Dr. Tamkin, who is going to take a session on hypertensive disorders of pregnancy, which is a very important cause for maternal mortality. So welcome all of you once again, and over to you, Dr. Tamkin. Thank you.
Good afternoon, everybody. We are going to talk about hypertensive disorders in pregnancy. And the objective for today's sessions are that by the end of this 1.5 hours, you will be able to define and classify hypertensive disorders of pregnancy. You will be able to explain its etiopathogenesis, how it occurs, and the pathology that is happening there because of it. You'll be able to describe its complications, to provide patients at the peri and discuss strategies hypertensive disorders in pregnancy. 19% of all maternal deaths occur because of hypertension in pregnancy. Leading cause of maternal deaths in India, that is 1/3 of all maternal deaths in our part of the world, that is India, they are occurring because of hypertension. The prevalence is about 5 to 10% in different studies from India and about 7.8% from National Health Portal. Incidence is again 8 to 10%. And out of these 8 to 10%, at least 2 will have a fit and will be at risk of serious morbidity and mortality. Prevalence is 5.4% of preeclampsia from the National Health Portal. So if you go according to the percentage of deaths that are occurring due to different causes in pregnancy, hypertensive disorders is a major cause of maternal deaths, along with hemorrhage and sepsis. And when we did for the last 10 years, we did our homework and we tried to find out what were the leading causes of maternal death. For us, it was very surprising to see that instead of hemorrhage, it was pregnancy-induced hypertension, which led to majority of maternal deaths. It is an absolutely preventable cause of maternal death. That is the saddest part. It is an absolutely preventable cause of maternal deaths. How to define a blood pressure of more than 140/90 on at least 2 consecutive readings, and the 2 should be taken 4 hours apart. Apart from that, whenever there is proteinuria in you, we all know edema has been removed from the definition of preeclampsia, eclampsia, whereas proteinuria is also now a questionable part of the diagnosis, okay? Because it has been noticed that some women will develop a fit or a convulsion even before proteinuria is happening, okay? Only hypertension without any proteinuria or any other target organ damage, it is gestational hypertension. When it is preeclampsia, again, you people told me it can be mild or severe type. So depending upon the certain criteria based on signs, symptoms, and investigations. Then it can be eclampsia when the woman has either convulsions or coma or both of them. Then chronic hypertension is a woman who becomes pregnant, who's already hypertensive and she becomes pregnant. Whereas pregnancy aggravated hypertension is that patient who has chronic hypertension, she becomes pregnant, and she now develops superimposed preeclampsia, mild or severe, or eclampsia. So these are the different types of spectrum of the disease that you see. Coming to the etiopathogenesis, you should all understand that in a non-pregnant, this is a non-pregnant, just see the vasculature of the myometrium and the endometrium. and here you see preeclampsia, and here you see a normal pregnancy. So what is happening in normal pregnancy? There is the trophoblastic tissue has got a burrowing property. So it is burrowing into the maternal tissues, and it is destroying the smooth muscle cells of the blood vessels. So the blood vessels will now become dilated, large sinuses will be formed. There will be no smooth muscle cells which will react to the vasopressors. So there will be no hemodynamic, there will be no effect of any hemodynamic instability in the mother on the fetus. So the basic loss of smooth muscle cells is there in the vasculature, in the vessels. This is happening in normal pregnancy. Why? Because of this burrowing property of the trophoblast. Now, what happens in preeclampsia, eclampsia? Either because of some genetic predisposition, along with some immunological reason, what happens that this proper, the destruction here of the vessels, which is happening right up to deeper into the into the layers of the uterus, this is not happening. The immunological reasons are there which will stop this burrowing. And as a result, what will happen? The vessels will retain their smooth muscle cells. They will respond to any vasopressor or vasodilator. And now what will happen? That there will be a hypoperfused placenta. Because of this, the placenta becomes hypoperfused. It will release certain substances, which will be vasopressors, which will be vasodilators, and there will be an imbalance of the vasopressors. They will increase in amount because of this production from the hypoperfused placenta. They will enter the maternal circulation, and they will go and cause vasospasm all over the body, in all the target organs of the woman. There will be vasospasm. So all the complications that are happening, all the clinical features that are happening are because of that. I repeat again, because of some genetic predisposition and some immunological reasons, there is an incomplete invasion of the maternal tissues, which results in a hypoperfused placenta, which produces certain vasoactive substances, which will cause vasospasm. These vasoactive substances will enter the maternal circulation, and all the complications that are happening, all the pathology that is happening is because of that. So there will be vasospasm in the head. There will be all those, edema will be there because of that. There will be convulsions because of the hypertension that is occurring. There can be intracranial hemorrhage. There can be bleeding from the nose. There can be bleeding from the GI tract. In the lungs, what will happen? It will be vasospasm will lead to increased workload on the heart. So what will happen? There'll be edema, the heart will go into failure. There'll be development of pulmonary edema in the eyes because of the edema that is happening in the brain. There'll be papillary edema. There can be retinal detachment. There can be hemorrhage in the hair, in the brain, which can, if it is occurring in the cortical area, it will affect her eyesight permanently. So from head to toe, it is so easy to remember the pathology as well as the complications as well as the clinical presentation. If you remember this basic pathology, that there is widespread vasospasm everywhere. So she can go into cardiac failure, she can go into pulmonary edema. In the abdomen, there are the kidneys. This vasospasm will decrease her urine output. She will go into acute tubular necrosis. If it is further not relieved, she will go into acute cortical necrosis. Because of the vasospasm that is happening, the capillary endotheliosis is there, the endothelium is damaged, and what is happening everywhere in the body, including the kidneys. If you remember your anatomy, your histology in the first year, from the first year MBBS, you'll remember that each and every vessel that is there in the blood body of a person also needs to be supplied by blood vessels, capillaries, and these are known as the capillaries of the vessel, which are known as the vasa vasorum. So once there is constant spasm in the blood vessel, what will happen? the wall itself will be damaged because the capillaries will be compressed and there will be no blood supply. So what will happen? The endothelium will be damaged. Whenever there is endothelial damage, what will happen? All the protein in the vessel wall will move out into the extravascular space. And once the protein moves out, the plasma also moves out, the fluid also moves out, and again, then the repair mechanism of the body will take over. What will happen? All these small holes that are occurring in the vessel because of the damage of the endothelium, what will happen? The platelets and the fibrin will come and try to plug all those holes. The repair mechanism of the body comes into play. So there will be hypofibrinogenemia and there will be low platelet count. That is where all the platelets are going. Why she will have a platelet count of 90,000 or 70,000 like that. And why she will go into DIC? Because of the fibrinogen which is being used up in repairing the body at the same time. And now what is happening after that? What happens? The another repair, what happens when you repair with fibrin and you repair with the platelet and form a clot? Again, the vessel needs to be recanalized. Otherwise, the blood supply to the tissue will be hampered. So now the other repair mechanism of the body, that is to lyse the clot, comes into place so that the vessel is quickly recanalized. So that is why she will go into disseminated intravascular clotting. So in the blood, there will be hypoalbuminemia, there will be hypofibrinogenemia, and there will be low platelet counts because of all this that is happening. Then again, in the abdomen, kidneys, I told you, acute tubular necrosis, acute cortical necrosis, and later on, then in uterus will be affected because of the vasospasm. There will be intrauterine growth retardation, there will be IUGR, there may be intrauterine death. And then there may be spontaneous hemorrhages between the muscle layers of the uterus, which you call uterine apoplexy. Then there can be spontaneous hemorrhages in the liver. So first of all the capsule, there will be small hemorrhages, then a large hematoma will form, and that is why the capsule of the liver will be stretched. Why? She will complain of persistent pain in the upper abdomen. Isn't it hypogastric pain, which we ask her again and again, or pain epigastrium, which we ask her again and again. So apart from GI hemorrhage, nasal bleed, which are all complications of any hypertension in the body, she will also have hemorrhage in the liver, she may have hemorrhage in the spleen, she may have spontaneous hemorrhages in the whole of the body. So these are the complications. If you remember them from head to toe, and you remember the basic pathology that is there, that there is some immune mediated incomplete invasion which leads to improper oxygenation of the trophoblast, which results in release of vasoactive substances which enter the maternal circulation and affect each and every organ. So vasospasm causes the hypertension in the head. There will be cerebral edema, there will be convulsions because of that. There can be brain hemorrhage, because of which the woman may die or she may be paralyzed. There may be hematemesis, there may be epistaxis, there may be cardiac failure because of the hypertension, there may be pulmonary edema because the fluid is seeping out, and because of the cardiac failure that is there, together they will combine. There will be thrombocytopenia, there will be low platelets, there will be raised liver enzymes because of that, there will be hemorrhages, subcapsular hemorrhages in the liver, spontaneous hemorrhages anywhere in the body, there will be acute tubular necrosis, there will be acute cortical necrosis, and then it will affect the baby with IUGR, oligohydramnios, and intrauterine death. So this is where it is being stopped and resulting in all these problems. So instead of large placental villi floating into the vessel walls, into the sinuses, you have a very tightly closed vessel here, which is there in preeclampsia and which is causing hypoperfused placenta. So genetic I talked about, I told you there is immunological intolerance. Some people say there is some platelet activation. There's a vascular endothelial damage. We already talked about that. There's an abnormal placental implantation. And then there are certain release of certain angiogenic factors and cardiovascular maladaptation to pregnancy, which lead to all this. So we already talked about what is gestational hypotension, when it is only hypertension with no evidence of any target organ damage. Preeclampsia, mild or non-severe type, when is decided according to the level of the blood pressure and also presence or absence of any sign and symptoms of target organ damage. So this is what I wanted to emphasize here, that now it is any blood pressure between 140 to 160 diastolic, systolic, 90 to 110 diastolic, with or without proteinuria will be preeclampsia. Severe hypertension, when it is more than one, severe preeclampsia, when blood pressure is more than 160 by 100 and 10 with or without proteinuria, but there is evidence of target organ damage. Whereas in this case, there is no evidence. So what are the evidences of target organ damage? Persistent headache, blurring of vision, epigastric pain, oliguria. I told you the blood pressure, it has to be remitted within 5 minutes. There will be hyperreflexia, pulmonary edema, liver enzymes will be deranged more than twice of the normal, as well as serum creatinine, platelets will be less than 1 lakh. So if anything like that is happening, then you know that patient is not non-severe, but she is severe preeclampsia. And eclampsia, when the blood pressure is more than 140 by 90 with or without proteinuria, but convulsions or coma or both may be there. So please remember, how do you differentiate? It is the presence or absence of convulsions which differentiates preeclampsia from eclampsia. And why we want to classify them into severe preeclampsia and non-severe preeclampsia? Because the management of severe preeclampsia is exactly the same as eclampsia. And there is impending morbidity and mortality in the mother and the baby. So they both have to be managed at the same time, okay, in a similar manner. We already discussed these complications. You can just see the list here: brain hemorrhage, thrombosis, edema, retinal detachment, cortical blindness. I already told you. Aspiration, yes. So when she is having a fit, she may also aspirate. So that is also one complication. Then it may result in bronchopneumonia, cardiac failure, GI hemorrhage, renal damage, as well as in the liver, there may be hematoma, hemorrhage, necrosis, and an entity which is known as HELP syndrome, which again denotes severe type of preeclampsia, eclampsia. In the blood, I told you there is vasospasm. So what will happen? There will be hemolysis. पतले पतले vessels से जब blood निकलेगा, there will be damage to the blood cells. So there is DIC later on, but initially there will be anemia, hypofibrinemia, and there will be raised fibrin degradation products. I told you that once the clot has formed, now the other repair mechanism of the body takes over, that of canalizing the vessel back into functioning vessel. So now what will happen? The fibrin degradation products will also increase. Then because of the convulsions, these complications may occur. Then uterus, we already talked about all these, and I also told you that she is at a higher risk of PPH, postpartum hemorrhage, because of the coagulopathy that is there. In the baby, there will be hypoxia, cerebral palsy, maternal retardation later on, IUGR, stillbirth, prematurity. Now, apart from that, there are also long-term effects in the mothers of eclampsia who have eclampsia, preeclampsia, that they are liable to develop hypertension later on in life. So, and in the next pregnancy, risk of recurrence in the next pregnancy as well. So what, according to you, are the important, I've shown you 4 causes of death. So which, according to you, is the most important cause? So can anybody unmute themselves and answer this question? Hello?
हेलो पार्टिसिपेंट्स, आप अनम्यूट करके आंसर दीजिए जो डॉक्टर तमकीन ने पूछा है.
Dr. Shail?
Aspiration of vomitus.
Okay, so you think it is one? Yes, it is one of the But what do you think is the most important?
अनम्यूट करना पड़ेगा.
जी हाँ बताइए, अनम्यूट करिए.
Intracerebral hemorrhage.
Hello.
Intracerebral hemorrhage. Yes, you are right. So the most important cause of death is, I also used to think aspiration of vomiters, है ना? But surprisingly, it is intracerebral hemorrhage, and that is why it is so important that we control the blood pressure very fast, effectively, and that is why you should know by the time you refer the patient and she reaches a facility, if you have not started the antihypertensive or you have not started, look here, this part also and this part also are related to you, so important that you prevent the convulsion, transfer her to the facility in such a manner that there is no risk of intracranial hemorrhage and no risk of aspiration because of a convulsion recurring. Importance of measuring the blood pressure should be measured at every antenatal visit. You all know that there should be at least 8 antenatal visits. But what is important is in the last 2 weeks, in the last trimester is most important, and also in the last 2 weeks it is very important that you should measure that. You'll be able to pick up the maximum cases of preeclampsia, eclampsia. You just saw that in India, and from statistics from JN Medical College for last 10 years, it is the major cause of maternal mortality. Okay. Then how do you record the blood pressure? The patient should be sitting or semi-reclining, slightly tilted to one side so that the right upper arm is well supported at the level of the heart. And it should be taken at least on 2 occasions, 4 hours apart. But please remember कि अगर 160 by 110 आपने रिकॉर्ड कर लिया तो आपको वेट नहीं करना है, अगले 5 मिनट बाद रिपीट करके उसका ट्रीटमेंट स्टार्ट कर दीजिए. वरना क्या होगा? Again, intracerebral hemorrhage, which is the leading cause of death. Now, these are the basic investigations that you need to send at the periphery. Get a CBC done, platelet count done, liver enzymes done, serum creatinine done, and ultrasound done. These will help you in deciding whether she's severe or whether it is mild, whether you want to manage her with yourself or you want to refer her. So these are the basic investigations that must be done. Now, how do you manage? The basic principles of management are, you need to control the hypertension first and foremost, and also prevent convulsions. And then you have to prevent the other complications I told you, isn't it? Renal damage, postpartum hemorrhage, all those complications. DIC. And then you also should know how to manage the complications if they have already occurred or she's coming late to you. Please remember, termination of pregnancy is the only cure for preeclampsia. Only treatment is terminate. Okay? And think of future prognosis also. Okay, of the patient. When to deliver. Okay, so I'm really happy that most of you already know the management, and I put this picture here just to emphasize one point, and that is our primary responsibility is to prevent a maternal mortality. Our primary responsibility is to prevent a maternal mortality. So we are not worried about the baby whenever the mother is in danger. So if she is severe preeclampsia or eclampsia, you will terminate. Only very few cases of severe preeclampsia, if they are less than 34 weeks, we will just wait for, we will just give them corticosteroids, and then we will terminate after that. So this is the algorithm. Whenever you have a patient of hypertensive disorder in pregnancy, you classify them into gestational hypertension, if non-severe preeclampsia, severe preeclampsia, and eclampsia. So if she is gestational hypertension, terminate at 37, but you have to increase the frequency of monitoring. You terminate non-severes again at 37. If she is severe, she is less than 34. terminate after steroids, provided there are no contraindications. Then only you will wait. If she is more than 34, terminate. The only difference is that both of these will be terminated, severe preeclampsia and eclampsia. But here your aim is to deliver her within 12 hours, and here your aim is to deliver her in 24 hours. Management of non-severe preeclampsia, more frequent visits, I already told you, regular blood pressure monitoring. This is the cutoff when you will admit the patient. Okay, please remember, I just highlighted it. Do not start the antihypertensive at a blood pressure less than 150 by 100. Why? Because it will cause further uteroplacental insufficiency, as well as it will give a false sense of security to the mother. The pathology will continue until and unless you deliver the baby. What will happen? It will only just hide the vasospasm. That is it. So the kidney damage, the cerebral edema, the cardiac complications, all those, the fetal complications, they will all continue. Only thing is that they will be masked because of the antihypertensive that you have given. So do not start any antihypertensive. You only start at 150 by 100. Why? Because now if it is beyond this, it results in formation of, it can cause intracerebral hemorrhage, which is the leading cause of death. So do not give antihypertensive and terminate at 37 weeks. Remember, our aim is for vaginal delivery. There is no role of diuretics. Okay? It is intravascular volume contraction. All the fluid is there. She's swollen up, but it is not within the vascular compartment of the mother. If you give her diuretics, it will again deplete the vascular compartment, can cause fetal death, fetal distress, and IUGR. There is no role of salt restriction. You already saw what was there, the etiopathogenesis, why it was happening, isn't it? So again, please remember, there is no role of salt restriction, and there is no role of absolute bed rest. She should be walking about according to her ability. Otherwise, there will be stasis of blood in the lower limbs. Edema is already there. What will happen? She will be predisposed to DVT, isn't it? So please allow her to move around. During admission, monitor her blood pressure twice daily and do the proteinuria at least daily. Maintain input-output charting, send these investigations, and counsel her about danger sign symptoms. Also, you should be worried about the baby, so advise her to look for fetal movements and do the monitoring where there is a very IUGR baby, wherever you think it is necessary, or a color Doppler if you suspect there is an FGR. Allow the blood pressure, the woman to stay at home if the daily home blood pressure monitoring is possible. She understands the danger signs and can visit the hospital whenever she is needed. Ensure bi-weekly visit to the health facility and weekly assessment of these parameters. But remember, this is only when the blood pressure is less than 150 by 100. Blood pressure is not controlled, keep her in the hospital for monitoring or refer to her district hospital, medical college for further follow-up. All women with severe preeclampsia should be referred to a medical college or a district hospital for delivery if not in active labor. Then management of severe preeclampsia, which you already said, you have to terminate, but only if one condition, when it is less than 34 weeks, you may think in terms of conservative management for a day or two so that the effect of steroid is there. So more than 34, terminate, and remember you have 24 hours to complete the delivery. If less than 34, stabilize, give her steroids if there is no contraindication, and then terminate after 48 hours. If she is very preterm, look here, this is almost a pre-viable baby. Hardly any nursery will be able to save that. Maybe if you have a very good nursery or working in a medical college and the woman insists, you might think in those terms. But less than 24 weeks, tell her there is hardly any hope for the baby. Please, if there's risk to you, please agree for termination. I hope I'm clear. Expectant management of severe preeclampsia should only be tried in a medical college or a district hospital and not at the FRU. Severe preeclampsia and eclampsia are managed in the same manner. Okay, severe preeclampsia and eclampsia. So hospitalize the patient, start an IV drip. Please restrict the amount of fluid. She's already overloaded. She can go into failure and pulmonary edema. Catheterize her, monitor the input, output, and proteinuria, control her blood pressure, give her prophylaxis for magnesium sulfate, just like you give for eclampsia. Plan termination of pregnancy in 24 hours for severe preeclampsia and 12 hours in eclampsia. Okay. How much time? Again, a repetition I want to emphasize. Please do not go on and on and on with induction. For severe preeclampsia, the delivery outcome will be much better if you deliver her within 24. And again, for eclampsia, the fit delivery interval, as it increases, the prognosis for the mother worsens. For the contraindications for, you will not wait even for steroids in this case. Okay. So when she has uncontrolled severe hypertension because of the risk of intracerebral hemorrhage, when she develops a fit, you know the prognosis will worsen if you wait now. If she has pulmonary edema, there is an abruption. When the abruption is there, you are going to wait for the baby. And here this will harm the baby, isn't it? Distress, fetal death. If you are waiting here, there is no faida because the baby is already dead. Now you are just risking the patients, the mother, to more morbidity and possible mortality. If it's a very small baby, again, no point in waiting. If she has gone into DIC, please do not wait for steroids. If she has gone into severe renal dysfunction, go ahead and deliver. Now, what do we next part? Few slides we will talk about how to control the blood pressure and how to control the fits. Two important problems, isn't it? So, how do you control the blood pressure? Antihypertensives, tablet alpha methyl dopa. You can use labetalol. You can use nifedipine, isn't it? For severe, you have to use tablet nifedipine. Please, no slow release. It is tablet nifedipine. Okay. And please remember, no sublingual nifedipine. It has to be always oral nifedipine. For acute hypertension, you have IV labetalol, but oral nifedipine. Okay, let's see how do you give it. So methyl dopa, it's the safest antihypertensive being used for prolonged periods in pregnancy for over many decades. Maximum dose is 2000. You can start with 250 or 500 BD or TDS in 3 to 4 divided doses. Mild and with slow onset of action. Blood pressure target may not be achieved on higher doses. It may cause somnolence. The patient will appear to be sleepy all the time. Oral labetalol, start with 100 to 200 milligram. You can give it BD or TDS, titrate according to blood pressure. Target is to maintain the blood pressure of 140 by 150, 140 to 150 systolic, or 90 to 100 diastolic. Look here. This is the target blood pressure. Do not decrease the blood pressure to a very low level. This is one picture of intracranial hemorrhage that I had put there to just remind you that if you do not control the blood pressure fast, it is going to result in problem in the mother. Okay. So you start injection labetalol IV 20 milligrams slowly over 2 minutes, then 10. After 10 minutes, if there is no blood fall in blood pressure, give 40 milligrams slowly. After 10 minutes, if still does not form, you can repeat 80. So look here. Two, three things you have to notice here. It is given over 2 minutes, not bolus, sudden bolus. And you repeat the next dose after every 10 minutes. And you are doubling the dose. Starting with 20, 10 minutes, again 40, 10 minutes, again 80. Up to a maximum of 140, which is recommended for you. Though you can, at medical college, we can increase the doses. Okay. So this is what I'm repeating again. 20 milligram Slow IVI over 2 minutes, wait for 10 minutes, 40, make it 10, again 80, wait for 10. Okay. So this is how you will give the. So now coming to the other drug, oral nifedipine for a hypertensive emergency. It can be given 10 milligram orally, if does, then wait for 20 minutes and then repeat 20 milligram. Then again, you might give it after another 20 minutes, but maximum dose is 30 to 50 milligram. So for you, it is recommended only not to try more than 30 milligram. So the first dose 10 milligram, wait for 20 minutes, and then give the next dose, which is doubled. Just like Levotrol, again it is doubled here. But it has to be oral, never sublingual. Okay? So if she does not respond to this, you have to then arrange for injection Levotrol. So if both of them are not available, then try tablet Levotrol. अगर कुछ भी नहीं है तो Levotrol ही दे दीजिए आप patient को. Okay? Don't send her to any other facility without taking care of the hypertension. So this is again the same algorithm, 10 milligram, 20 milligram. If this does not respond, switch over to IV Levotrol. And here you are waiting for 20 minutes each. Okay. Again, I'm emphasizing, do not bring it back to normal. Maintain, this is the level at which you have to maintain. Okay. Then once the blood pressure threshold has been achieved, repeat every 15 minutes. So do not just, once she had a hypertensive crisis, you gave her and it became normal and then now you have forgotten her. Please remember, for the first 1 hour, you have to monitor her every 15 minutes. For the next 1 hour, you have to monitor her every 30 minutes. And for another 4 hours, you have to monitor her hourly. So be vigilant even after once you have administered the antihypertensive. Now the second aim was to prevent the convulsions. So for that we will use the PreTerm regime. It consists of 4 grams of loading dose IVI as 20% solution. You can use 2 regimes. One is completely all doses intramuscular. Another is the maintenance dose is intramuscular. Another one is where you have to give it IV. But you start with IV in both the cases. So 4 gram loading IVI as 20% solution. And then another you have to give 5 milligram into each buttock. So again, 5 milligram in each of the buttocks. And continue the maintenance dose every 4 hours for 24 hours after delivery or after the last convulsion. Okay. So whichever occurs later, you have to continue that. This is regime. It is another regime where you give 4 grams loading dose as 20% solution followed by 1 gram per hour for 24 hours after delivery or last conversion. Okay. 4 grams as 20% solution in normal saline. How do you make that? How do you administer the drug? So 1 gram is there in 1 vial which has 2 ml in it. Okay. Dissolved in 2 ml of solution. Then 4 vials is equal to 4 grams is equal to 8 ml. Now you want to make it a 20% solution. So you now add 12 ml of normal saline to it. This is total solution because 20 ml and this solution is given over 15 minutes. So just remember 4 vials you have to take and add 12 ml of normal saline. That's it. 4 vials and you add normal saline. Okay. Then 50% means 0.5 gram in 1 ml. So for the intramuscular dose, you have to give very concentrated, isn't it? Because if you give a huge amount, it will be such a painful injection for the mother. So each ampule contains 1 gram in 2 ml. So therefore, it is already a 50% solution. For 5 grams, directly give 5 ampules in 1 buttock and 5 ampules in another buttock. This is the loading dose. Okay. If fits are recurring after 30 minutes of loading dose, you can repeat 2 gram IVI and as 20% solution slow over 5 minutes. Respiratory rate, remember, should be more than 16 breaths. Patellar reflex should be checked. Urine output is at least 100 ml over last 4 hours. And the contraindications are that there should not be any renal failure. Woman should not have myasthenia gravis, and cardiac disease is also a contraindication relative. So watch for toxicity signs before every maintenance dose, the next dose that you administer. Let's have a look at the safety profile of magnesium sulfate. This is the therapeutic level of magnesium sulfate. Maternal toxicity is rare if given carefully and patient is monitored properly. Absent patellar reflex कितने लेवल पे जाएगा जब इतना डोज इकट्ठे हो जाएगी बॉडी में. रेस्पिरेटरी पैरालिसिस कब होगी जब इतनी हो जाएगी, और कार्डियक अरेस्ट होगा जब ऑलमोस्ट 13 मिली इक्विवेलेंट्स हो जाएगा. सो सी हियर, दिस इज जस्ट अराउंड 2 to 3. Whereas patellar reflex जो है आपके पास टाइम है, अगर आप ठीक से पेशेंट को मॉनिटर कर रहे हैं आप पकड़ लेंगे. उसके बाद रेस्पिरेटरी रेट जाएगा, उसके बाद कार्डियक अरेस्ट होगा. So the only solution is that you monitor her carefully. It's a safe drug if you give it with the proper monitoring. So we now come to the intrapartum care. Intrapartum care, measure the blood pressure every 30 to 60 minutes. Ambulate according to her general condition. Epidural can be given. Aim for vaginal delivery unless otherwise indicated. So next, please. If you are an expert in forceps application, you may use this, cut short the second stage. Please remember, do not do any meddlesome midwifery. If you do not know how to use the forceps, let her deliver on her own. What is important is that the third stage, there is no methotrexate should be given, and use only oxytocin or misoprostol for management of third stage of labor. Remember, these patients have volume contraction and they have very limited ability to withstand postpartum hemorrhage. So while you're managing this woman, do not wait for the mandate कि जब 500 ml हो जाएगा तब हम PPH label करेंगे, तब हम इस patient को manage करेंगे. Okay? So please remember, these women have very limited ability to withstand postpartum hemorrhage. So start management immediately. Spinal anesthesia is safe for these women, as intubation for these women may be difficult because of the edema that is there. Next, please. The intrapartum care do's and don'ts: measure the blood pressure every 30 to 60 minutes. Ambulate according to her general condition. Restrict her fluid intake. Epidural. Aim for vaginal delivery. Next. Continue the magnesium sulfate during labor, during delivery, during cesarean section. Okay. Next, please. So you have all seen this woman. Can you click on that? Maybe she will move. So all of you, can you just tell me the management of this woman? सबसे पहले उसको करवट से करेंगे, उसे प्रोटेक्ट करेंगे. उसके बाद माउथ गैग आपने बताया. उसके बाद तो कौन सी पोजीशन है जो इसको हेल्प करेगी?
Left lateral position.
Yes, left lateral with head slightly tilted, isn't it? So immediately you put her in that position, you clear the airway, you check and put in the mouth gag, and then you go ahead and do the other thing that you said, a large bore cannula. That is an emergency for a PPH case. For this one, it is the positioning and protecting the woman. Okay, airway सबसे ज़्यादा important है इसका. उसके बाद आपने इसको वो लगाया, फिर आपने कैथेटर डाला, फिर आपने ऑक्सीजन लगाई. नेक्स्ट स्लाइड प्लीज. नेक्स्ट. यस. So control of blood pressure, I told you, control of convulsions, terminate, and we should deliver within 12 hours. This is very clear. And please remember, it is not an indication for cesarean section. Next. Next, please. Call for help, or rather I will say shout for help. इतनी emergency है. Airway, protect the tongue. Position, prevent a fall. Oxygen, 2 IV lines. Catheterize or magnesium sulfate, give her magnesium sulfate. Labetalol, send investigations, and do not forget the fetus. सो जैसे आपने आईवी लाइन लगाई, आपने मैग्नीशियम सल्फेट तैयार करवा लिया, आपने कैथेटर डाल के फौरन ये देख लिया कि बिल्कुल एनयूरिया में तो वो नहीं है, और उसके बाद आपने फीटस को भी ध्यान में रखा एंड यू सेंड द investigations through the same. So I hope you will remember now, unlike PPH, here it is the airway which you need to protect first and prevent her from a fall. इतनी ऊंची वो पलंग से 1-1 फीट ऊंची कभी कभी उछलती है, इतना टॉनिक क्लॉनिक कन्वर्जन होता है. ओके, सो इज दैट ओके डॉक्टर सीमा?
Yes, it's a very good thing that you explained, क्योंकि फोलीज कैथेटर जो डलता है वो एन्यूरिया नहीं देखेंगे तो पता लगा मैक्सेल्फ दिया और टॉक्सिसिटी शुरू. ठीक है. Yeah.
Okay, next.
Thank you.
Welcome. So what will you include in your eclampsia kit? You all have that. Just I'm showing you what you will include. Next, please. Antihypertensive drugs. And please use the drug with which you are experienced, you are comfortable. Both have been, whether it is tablet nifedipine or it is tablet labetalol, they are equally good. Okay. So there's some heading I have written wrong. This is just the drugs. It includes magnesium sulfate. Magnesium sulfate is not an antihypertensive. Please, I'm sorry. Then injection labetalol, tablet nifedipine, and the antidote should be there. Okay, and lignoran if you are using intramuscular. Then you should include your equipment also should be there. Your venous cannula should be there, and the IV fluid should be there. Next, and the syringes should be there, and the Foley's catheter should be there. So please remember that there should not be any convulsions. Sorry, please remember that convulsions may occur with even normal blood pressure and with no evidence of target organ dysfunction. This is one, I'm telling you, one important rule that you should remember, that all fits during pregnancy have to be treated as, should be treated as eclampsia unless proven otherwise. So if you are waiting for a diagnosis, you are not finding that the BP is high, but the patient is convulsing, for any type of convulsion, the management is the same, that is magnesium sulfate in pregnancy. Okay, unless you know that she is an already eclamptic woman, then only you will give her phenytoin. Okay, it has the best safety profile and it is the most effective drug in controlling convulsions of preeclampsia, eclampsia. Okay, next please. So now if you have seen this patient, you have done the initial resuscitation. If you are at a CHC, please do not transfer her without giving her the first dose of antihypertensive and the first dose of magnesium sulfate. Okay, so total at the CHC, just give 5 milligram in each buttock and then you transfer her to the FRU. At the FRU, the first dose is 14, isn't it? I told you 4 grams as IV 20% solution, 5 grams as 50% solution in both the buttocks. Next, please. We already discussed that in detail. And then every 4 hours, you have to first check for the respiratory rate, for the urine output, for the patellar reflex, and then only administer the next dose. Next, please. Do not forget the baby. And I told you after every fit, there will be some uteroplacental insufficiency, but please wait for that patient to recover from that vasospasm, and later on, if it is persisting, most of the time the hypoxia that is occurring, the patient will respond to your management, the baby will respond, but if it is persistent, then take her up for cesarean section. Okay, so 2 things I have told you, that eclampsia, preeclampsia, aim for vaginal delivery. Okay, but for fetal distress, you have to terminate by cesarean section. Next slide, please. If the woman continues to have convulsions, you may give additional 2 milligram. Okay, but again, if she has not responded to 2 additional boluses, switch over to another drug. You can use diazepam or you can use phenytoin. Okay, so diazepam you have to give every 5 minutes, 5 to 10 minutes, 5 to 10 milligram, maximum 30 milligram, not more than that. Okay, and it is not a very good drug for eclampsia. only if magnesium sulfate is not available, or only when you are unable to control the seizures after 2 additional, uh, doses, then only you have to switch over to magnesium. The woman who's managed with diazepam in eclampsia has a poorer outcome as compared to a woman who is managed on pre-eclampsia, eclampsia. Oh, sorry, on magnesium sulfate. Next, please. In the postpartum, you have to continue the antihypertensive drug if blood pressure is more than 150 by 100. So labetalol or nifedipine or amlodipine, but do not give methyl dopa because that can affect the baby of the woman. Strict blood pressure monitoring for 72 hours and call her for follow-up after 1 week. If new onset hypertension is there with headache and blurring of vision, give her magnesium sulfate. So for example, you delivered a woman of severe preeclampsia, but later on she starts having those features of impending eclampsia, then you have to start her on magnesium sulfate. Weekly blood pressure after discharge till her blood pressure returns to normal, and annual blood pressure, blood sugar and lipid profile is advised because these women, they have long-term risk of developing ischemic heart disease, renal disease and hypertension. So again, educate her that in the next pregnancy also she may have a recurrence of preeclampsia or eclampsia. So it should be a book delivery in a hospital for next time as well. Next, please. What do you tell her at the time of discharge? Tell her that it's a serious disease, there's a risk of recurrence, and it can happen to any woman. She may lose herself, she may lose a baby, and there's a risk of stroke, seizures, organ damage, death. So ideally, all women who are coming to you at antenatal women, at antenatal clinic, you should take this opportunity to educate them about the complications which may occur in pregnancy. Okay, next please. Next. Next slide, please.
Anjali?
So usually we do the group counseling for these women. So I told you, what is important is that blood pressure should be checked every time she comes for the antenatal visits, a minimum of 8 antenatal visits as advocated by the latest guidelines by WHO. It is not, for low resource setting, just 4 visits, 1 visit in each trimester. They have done lots of studies and they have found that when you restrict the amount of, when you restrict the number of number of visits, you also restrict the उन लोगों का चला गया
आ रही है आवाज
आ रही है अच्छा अच्छा
जी जी
I will continue. So when you restrict the number of antenatal visits, the outcome of pregnancy is poorer. Okay, let me just hold on 1 minute.
I think Anjali's
PowerPoint is gone. Okay,
yeah.
I will continue that way. Let me go to my slides.
आ गई
Okay, so you also have to advise her about the warning symptoms and signs and of hypertension. Persistent pain, severe headache, feeling nauseous or vomiting is there. Then there is blurring of vision, swelling in your hands and face, and shortness of breath. Next, please. So she has to return for follow-up within 1 week of discharge. Look out for warning signs. Return if she notices any abnormal signs, symptoms. Keep all follow-up appointments. And if she feels that she's not okay, she's the best judge to tell us. Okay, and come back. Next, please. WHO recommends that you can use calcium supplementation. And therefore, Government of India also recommends that for every pregnant woman, just 1 minute. Oh, sorry. For every pregnant woman, she should receive 2 tablets of elemental iron and vitamin D for 6 months during antenatal period after first trimester, and for at least 6 months during lactation. So this is this may help in preventing or decreasing the incidence of preeclampsia, eclampsia. But Cochrane says that it will help only if the population is deficient in vitamin D and deficient in calcium, which most of our women are. Okay, next please. Next please, next slide. So sometimes when she's not responding to magnesium sulfate, you have given her 2 more doses, then you have to start phenytoin, which is given in an initial dose of 10 to 15 milligram per kg body weight. Again, it is given not as a bolus, but as an infusion over 30 to 40 minutes. And the maintenance dose is just half of that, 5 to 7.5 milligram. And then you have to continue it because you cannot just stop it immediately. When you give phenytoin, it has to be tapered off slowly. So continue it till 7 to 10 days postpartum, and like magnesium sulfate. Next, please. Next, please. Yes. Again, we have used a lot of aspirin, and there studies have been done on thousands and thousands of women, and they have found that aspirin is beneficial because it improves the endothelial dysfunction that is happening, and the platelet function as well, it improves. And 75 milligram to 150 milligram daily from 13th to 36th week of pregnancy. So that is the change here. Earlier we were saying that it should be given till 34 weeks of pregnancy, but now we continue it till 36 weeks. So especially for those women who are high risk for developing preeclampsia, like they are twins, or they are becoming pregnant for the first time, they are diabetics, they have a family history of preeclampsia, eclampsia, or hypertension, they themselves are hypertensive. So all these women will benefit by giving prophylactic ecosprin. Next, please. So there are a lot of challenges which are there, because of which the women will develop hypertensive disorders. One of them is, of course, lack of awareness, the low economic status. They do not have the resources to be able to go and seek care. There's poor transport, lack of modalities for risk identification. There is no uniform guideline how to recognize that this particular woman will go into preeclampsia, eclampsia. Lack of expert antenatal care with a multidisciplinary approach, scarcity of HDU and ICUs. All these issues have created a huge unmet need in recognizing and managing these disorders and its complications.